Why are young people getting diagnosed with diseases that used to only be diagnosed in much later life? Today, we are diving deep into the root cause of why this is happening and how you can prevent it. Hey, everybody, welcome back, and thank you for joining me on the Terri Show today. Joining me today is Dr. Ken Johnson. Dr. Johnson has been a practicing interventional cardiologist and endovascular specialist, big words, in the Dallas-Fort Worth Metroplex for 25 years. He co-founded the Balanced Vitality Institute for Cellular Health and Longevity. Dr. Johnson blends his deep knowledge of cardiovascular wellness and prevention with this comprehensive, functional approach to providing disease prevention, wellness, and longevity. Love longevity conversations. Here's a question. Can diabetes be solved? Instead of jumping on the pharma treadmill, listen in today as Dr. Ken talks about how he's seeing it solved often in his clinic and why this isn't adopted widely. Stay tuned until the end of the show today to hear Dr. Johnson's tips on how to decrease your toxic load starting today. In this episode, we talk about microplastics and the havoc they're wreaking in our bodies, even more than we first knew, toxin overload and what this leads to in our health. What is BPA and BPA free, and is that really making a difference? The true root of inflammation and where and why it's happening in your body. We also talked to Dr. Johnson about Dr. Johnson's book on microinflammation and what he's doing at his clinic these days to help people find healing and restoration in their lives. Here's my conversation with Dr. Johnson. Okay. Welcome, Dr. Johnson.
Thank you.
Thanks for being here, taking time out of your busy day. I'm so excited to talk to you, and really excited because, we met each other initially because of our mutual love of hormones. But then, I've also known you as my husband and I came in and chatted with you, and I really got to know more about your practice by coming to your practice, and just fascinating what you're doing there. And I really do want to talk a lot about that because it's unconventional. You're a cardiologist, and you've got all kinds of amazing certifications and just so pedigreed. And you have a story of going from this conventional. So you didn't really go from, but it sounds like you kind of brought in a different approach to your practice from conventional cardiology. So before we kind of get into talking about what I really want to talk about, I really just want to hear your story.
Sure.
And how did you start where you started and get to where you are now?
Sure. So, I've been an interventional cardiologist for 25 years, but I realized early on that we were doing a poor job in prevention and really kind of cardiovascular wellness. But in addition to that, it's funny you mentioned hormones, because that was actually, when I think back, the inciting event that led me down the path of functional medicine.
Interesting. Okay.
And so I was attending all my usual cardiology meetings, the American College of Cardiology, American Heart Association, and all this data was emerging with testosterone deficiency, particularly in men, as a risk factor for coronary disease and diabetes.
Thank you for paying attention to the literature.
So it's funny. I said, okay, well, I need to be proactive. And so I started checking testosterone levels. Yeah. But then I didn't know what to do with it.
Right.
So I'd send my patients to endocrinologists. Well, guess what? They didn't know what to do with it either. So my patients would come back 6 months later, and I'd have in the chart that I sent them, and I said, oh, what'd they do with your testosterone? They said, oh, it's fine.
Nothing. They said it's normal.
So that actually started my quest into understanding how to give testosterone to men in particular.
Right.
Which obviously then led to understanding how to give testosterone to women.
Right.
And you keep finding new rabbit holes in that space. And so hormones led to this whole world of functional medicine that I'd never heard of. And so I kept diving deeper, and then I started making the connections. Oh, this is where the wellness is. This is where the prevention is. It's not what I learned in medical school. Yeah. It's this other science that no one has ever explained to me. So, I took it upon myself to get certified in the functional medicine space. And of course, that then led to longevity and anti-aging, natural cousins to one another. And so I got certified in that realm. And so I took the path from cardiology to aggressive prevention, and then the most aggressive step is wellness in the younger patients so that they never have to face coronary disease ever again.
Yeah.
And so I ended up here, and so I'm still practicing cardiology full time, and I have my functional medicine / longevity practice as well.
So I'm curious because when I first got into this space, I also still worked in the hospital, and I kept my job as working with a hospitalist group in emergency medicine. But then as the more I learned on the integrative functional side of healthcare and prevention and disease prevention, I started having this kind of war with myself of, I couldn't really talk about, or I didn't have those solutions for the patients in the hospital, and I knew there was kind of a better way. But how are you able to marry the two? Because I know you see patients at a regular cardiology office, and then your primary is your other longevity medicine office. But how do you blend those two?
Yeah, well, fortunately, it's easier in the outpatient realm. So the hospitals are bureaucracies, as you know from your personal.
What to do.
Yeah, so you don't really have the license to implement alternative therapies in the hospital, or else you look like a heretic.
Right, exactly.
But in the outpatient space, there's a lot more flexibility, and so I was able to, I started off with doing advanced biomarker testing with my cardiology clinic patients. So I used the functional medicine lab at the Cleveland Clinic, run by Mark Hyman at the time, and so that opened up my world to a whole host of new biomarkers that really did a deep dive on patient risk assessment. And so that was a natural fit. And then I could start implementing therapies in addition to writing prescriptions. Right. So I could talk to patients about omega-3s or the importance of B vitamins in cardiometabolic health, or whatever the topic was. And so it was an easy transition there. And I think you just hit it on the head. If you get the bureaucracy out of the way, which was the hospital, you have more license to do what you want to do. Doctors, for the most part, even though I worked for a large group, you have a lot of autonomy in how you manage your own individual patients. Yeah,
that's awesome. So let's talk a little bit about how you already mentioned you kind of started in your more functional space, kind of with hormones, and then you added this and you added that. Did you just start kind of practicing some of these things you were learning from your certifications in your conventional cardiology group, and then eventually opened your own, or did it make more sense to just kind of open your own place that's completely separate, or how did you make that transition?
I definitely started with my cardiology patients. Yeah. So, as a good scientist does, I experimented with them.
Practicing medicine.
It's all about risk benefit. And it's interesting that as much as some people may balk at some of the functional therapies, the downside risks to most of them is pretty minimal compared to some of the prescription drugs that are out there. And so it was an easy thing to start talking about hormones and nutraceuticals. Right. And then, where I found myself hamstrung in a lot of ways is I wanted to do even more advanced therapies like NAD infusions, ozone therapy, stem cells, and that wasn't really going to be acceptable in the cardiovascular space. So I think wanting to do more because of my knowledge base had expanded so much, I needed to move out and form a separate practice. So that's how I did it. But there was a several year time span where I did it exclusively in my cardiology clinic.
Well, I want to just, because we started with it and talked about it, I want to talk a little bit about the hormone piece, but then I want to really get into something that we're both very passionate about, and that's inflammation and as a root cause of so many diseases. But just for the listeners, because, there's always confusion around hormones. And you said something really important of how you would test your patients and realize that they were not optimal, but send them to a conventional clinician who told them they were normal. And so talk a little bit about that as far as when you're looking at labs in the hormone world, especially as it relates to inflammation and cardiovascular disease protection. I know in the literature that we teach on and that I've seen myself and spoken on, what we're seeing is better benefits and better outcomes and decreased mortality and decreased cardiovascular risk when men and women, for that matter, have their testosterone levels in the upper end of that reference range, or the upper tertile of that reference range. And so one of the things I'm always trying to explain to people is that reference range on your lab that your clinician, your doctor, your practitioner, whoever might be getting, that's not, we call it normal, but it's really what's expected. So how do you explain that whole conversation to your patients when you're trying to get them to explore, hormones as a root cause?
Yeah, it's very funny you mentioned that, because I'll pull out a lab report. One of the things I use to teach my patients, I'll pull out a lab report from 20 years ago. And you probably recall the reference range used to be called the normal range.
That's right.
And I explained to them, I said, do you see the difference here? I said, the reason is that this range has nothing to do with normal. Right. It has to do with observations in random populations.
Right.
So the way I explain that to them is that in order to understand normal, we have to go back to physiology and understand when you were functioning at your maximum capacity, what was your testosterone at that time? What was your growth hormone at that time? What was your estradiol at that time? And what is it today? Because there's no such thing in the functional medicine space as normal for age.
Correct,
And so patients and physicians are taught that, testosterone declines with age. That's normal.
Right. And it is.
It is a normal for it to decline, but it's also the manifestation of what I consider the aging disease process. Right. Aging is a disease.
Right.
We don't have the cure for it, but we can treat it.
Yeah.
Hormones are some of the foundational treatments for aging. Mm-hmm. And the second half of that statement has to be, okay, if you think that my testosterone should be 800, 900, 1,000, is it safe for it to be that when I'm 72 years old? And the answer unequivocally, through millions of patients in trials that you're quite familiar with, is yes.
Yes.
And in fact, you derive a benefit from that.
Yeah,
so that's I have that conversation with everybody.
Yeah,
and I think that they get it.
Yeah. Well, and especially when, you explain that number for a male, let's talk about males, because there really are no established really good ranges for women, unless you're looking at free testosterone, really. But for males, that optimal, I like to use the word optimal, because when men felt the best and they had the most energy and their, brain was firing on all cylinders, they were probably up around 900, 1100, somewhere in there. And when I have that conversation with guys, you talk about when is the time in your life that you felt the best and you were just, firing all cylinders. Well, probably in their 20s. Yeah. And that's about what is normal in their 20s, although that's a different story today, and I want to talk about that a little bit. But I did have a guy one time, and I love this analogy. He said, I have the energy, the vitality, the mental clarity of my youth, but the wisdom of age to know what to do with it. I was like, that's perfect. Yeah. That is so perfect. But are you seeing in your practice, and I don't know, your age demographic might be an older population, but I know in our world, we are seeing more and more younger people coming to us with hormone dysfunction, metabolic dysfunction, even early cardiovascular disease. So let's talk about that a little bit.
Yeah, for sure. So in my longevity practice, I see late teenage patients, 16 and above.
You go all across the age span.
And I'm glad you brought this topic up, because I'm seeing these striking testosterone deficiencies in college students that they come in feeling, it's funny. If I were to diagnose them without doing their blood work, I'd say they had Epstein-Barr.
Yeah.
Something, right?
Yeah.
Totally fatigued, can't think, can't get out of bed. And I check their testosterone level. Literally, I had this SMU kid the other day with a testosterone level of 191. He's a 20-year-old male.
Yeah, that's devastating.
So, I think, I don't know if this is what you wanted to get into, but toxicity, toxins.
This is exactly what I want to talk about.
It's been clearly shown in trials that two of the biggest offenders, glyphosates and microplastics, clearly lead to reductions in testosterone in both men and women. And I think we're seeing that, as well as other toxins that we haven't yet identified.
Absolutely.
But the two big players. And so, definitely younger and younger patients with abhorrently low testosterone levels.
And it has, everything to do with the food, the gut, lipopolysaccharides, plastics, all the toxins that we're taking in. And, and then, of course, in the South, we see a lot of traumatic head injuries, which can also impact that too. But I agree. And we're seeing, just like you said, in their 20s. Now, do you see that when you have these young patients like this and you get them on a program to detox and get them their lifestyle, and I'm sure, and I'm anxious to hear how you approach this. I'm sure it's lifestyle and diet and all those things, but are you able to see them turn that somewhat without adding hormone therapy in these younger populations, or how do you approach that?
So certainly detoxification protocol, and it's fun. I mentioned Epstein-Barr because I find that with a high frequency in young patients too. Mm-hmm. And there has been the literature is not as strong, but there is an association with chronic Epstein-Barr or reactivated Epstein-Barr and low testosterone.
Okay, interesting.
So I have a Epstein-Barr detoxification protocol. It's actually, if you think about it, it's the same disease as long COVID.
Right.
It's this bad humors from these viruses that stay in the bloodstream or reactivate in the bloodstream and cause these physiologic defects. Right. So I'll detox these people and I will do that before I implement any kind of hormone therapy. And I've seen some dramatic improvements, especially when, I have patients with documented Epstein-Barr. Their testosterone levels will come up, several hundred points.
That's awesome.
But I'll tell you, do they ever get back to 800, 900, 1,000? I haven't seen that.
Yeah.
I think that there's some permanent damage there.
Yeah, interesting. So some of them might need to be on therapy at least until they're, ready to have children or whatever.
Sure.
Yeah, that's interesting. So you talked about microplastics, and it's interesting that, that I didn't plan on going here, but this is a great conversation. I had this conversation with another doctor not just recently, and she was talking about plasma exchange as a way to, probably the only way to talk about, because we're getting into the inflammation conversation slowly, but talk about plastics and what you know about what plastics are doing in our body. I mean, it's unbelievable.
It is fascinating, the physiology. These microplastics can actually go intracellular and cause mitochondrial disruption. Isn't that? I didn't believe that. So the first reports were that they can instigate inflammatory pathways, which made sense. Uh-huh. Okay, so you get these microplastics, they stimulate the release of these bad cytokines that then promote inflammation throughout the body. That made sense. Then I started reaching deeper and find out that they can get intracellular into the mitochondria and cause mitochondrial dysfunction, which is probably the root of even the inflammatory process is really going down to the cellular level at the mitochondria.
The mitochondria is everything.
Yeah, you're affecting the core of the machine.
Right.
So it's just unbelievable that these toxins can do this.
So for our listeners, explain what are microplastics and how do we get exposed and how can we best avoid?
Sure. So microplastics, I mean, as the name implies, they're just kind of fragments of all the plastics that we use from plastic water bottles to, containers that we store food in. And you can look at it as these small particles just kind of shave off, and they leach into your foods, leach into your water, liquids, whatever the container is, and then you ingest them. They're so small that they get absorbed through the gut into the bloodstream, and then now we're discovering they can actually permeate the cell and go intracellular. So, it's scary.
It is scary, and I think we're just now seeing a lot of the repercussions of using all of this plastic over since when. I mean, we didn't have plastic water bottles when I was a kid. You drink from a water fountain or you just got a glass. We didn't even have plastic cups, really. So I guess this is how many decades of plastic use, it's just now kind of surfacing as a problem.
Right.
But, it's a multi-billion-dollar industry, all these plastic water bottles.
Yeah, because even if you think about countries that are more proactive about getting toxins out of their systems, they still use plastic.
They still use plastic.
I travel all over the world, and I'd say, for example, the UK is more progressive than us on trying to eliminate toxins, but they have bottles of water everywhere you go there.
Right. Well, and you gotta cater to the mainstream, to the masses, I guess.
And so, I think one of the disconnects is a lot of these bottles now say BPA free.
Yes.
Okay. Well,
talk about that.
Yeah. So BPA is another potential toxin, but it's different than the microscopic plastic particles that are coming, that are being shaved off.
So it's
plastic.
It's kind of giving you a false sense of security that this water bottle that's BPA free is going to be somehow better for you. Just use glass.
Yeah, exactly.
Just use glass, or stainless steel or something like that. But so we we're kind of leading into this inflammation conversation, and plastics are a part of it, and all the toxins, and like you said, with young people, food, and all of those things. But let's talk a little bit about, let's kind of scratch the surface of really what, when you peel back all these onion layers of these disease processes, and you came from the cardiology world, but now you're in functional medicine space, so you're looking at every chronic disease process and the root cause. So let's talk about the root cause.
Sure. I think that the root cause really lies in what I call microinflammation. And I wrote a book called Understanding Microinflammation. Yes. And what really, the genesis of that book was that there was an overwhelming body of evidence in cardiology that was supporting inflammation as really the foundation of coronary disease.
Yeah, it's not a statin deficiency.
Exactly.
Or high cholesterol,
exactly.
I should say.
And then I started talking to a friend of mine who's an oncologist who I wrote the book with.
Yeah.
And he said, this is interesting. I just got back from the American Society of Clinical Oncology, and all the conversations were about the inflammatory basis of cancer. So then I did a deep dive, and I realized that almost every disease process you can think of has an inflammatory component. Alzheimer's disease, yep. Parkinson's. And then, as I mentioned earlier, in the functional space, we view aging as a disease.
Sure.
Premature aging, or aging in and of itself, is an inflammatory process. So it's important, though, to understand a lot of people, when they hear the term inflammation, they think of a sore joint. We're not talking about inflammation at the macroscopic level. We're talking about inflammation that occurs at the cellular level, which really ultimately, if we wanted to define that better, we would say mitochondrial dysfunction.
Right.
So mitochondrial dysfunction related to bad habits, toxins, even just exposure to radiation from the sun.
Mm-hmm.
Our
even
mitochondria,
breathing the air.
Our mitochondria get damaged, and we have repair mechanisms that are designed to counteract all the adverse forces that we encounter every day, but sometimes they're not sufficient, particularly if you lead a poor lifestyle.
Right.
You don't have the reserves to fight off that, and so your mitochondria start to die. The mitochondria are critical to creating energy, yep. and processes in your body. And so that really is where the inflammation's coming from, is the dysfunctional mitochondria.
Yep, absolutely. And there's a whole conversation about mitochondrial dysfunction, and there's so many things that impact it. Melatonin decreases, and diet and toxicity, not only from the food and the air, the environment, but also what we're scrolling, what we're reading, sure. what we're letting into our thoughts. I mean, it's a whole big conversation. So talk about the link, between this microinflammation and how, and let's just start with cardiovascular system.
Sure.
Let's just talk about that first.
Sure. So the cardiovascular system, obviously, what we're talking about is coronary disease or plaque formation in the arteries. So the wall of the artery is its own living, breathing machine. Mm-hmm. And in the setting of mitochondrial dysfunction and the appearance of inflammatory mediators, the wall of the artery gets damaged. And when the wall of the artery gets damaged, it actually becomes susceptible to absorbing cholesterol particles. Mm-hmm. And that's really the inciting event that causes cholesterol molecules to accumulate in the wall of the artery. It's no longer that, just because you have high circulating amount of particles, yeah. that's going to cause it. You have to have the endothelial dysfunction, or the cellular dysfunction at the layer of the blood vessel wall, to instigate that event. Yeah. And so, once that happens, there's a propagation of cellular events that become a vicious cycle where plaque formation leads to more inflammation, yeah. which then leads to more plaque formation. Yeah. And that's why coronary disease continues to be the number one killer, worldwide.
Well, and despite our, the uptick in all the conventional modern medicines and things like that are, trying to address it, but it doesn't seem like, and this is your world, not mine, so I'm not, maybe there is, but it doesn't seem like there's a lot of emphasis being put on inflammation and mitigating inflammation in the body as an approach to cardiovascular disease. Is that?
And that's a fair statement. But here's an interesting dichotomy from that perspective. So once it became pervasive in the cardiology literature that inflammation was the inciting event, cardiologists and researchers decided that they look at inflammatory markers that were associated with increased cardiovascular events. And you're familiar with most of them: myeloperoxidase, CRP, LPPLA2. So, and all of those are associated with increased risk of cardiovascular events, including heart attack and stroke.
Yep.
But then what happened? No treatment came.
What do you do with
actually,
it?
the only treatment, you know what the only treatment they said, the basic consensus was, well, statins have a pleiotropic effect of being anti-inflammatory. So that must be the therapy for these inflammatory markers. And as
and
as you know from the investigations that I do, I do a deep dive into the biomarkers, and so that's where functional cardiology separates from traditional cardiology.
Good.
Because in traditional cardiology, you see elevated lipids, elevated inflammatory markers. You treat the lipids, and you say, oh, it's interesting that the inflammatory markers are elevated. That proves this is an inflammatory process. But there's no directed therapies against those. Whereas on my side of the fence in functional cardiology, I'm like, oh, elevated lipids, elevated inflammatory markers, man, I got to get rid of the inflammation.
Right, because is it if you address the inflammation, don't the lipids follow? Oftentimes. And
then, you even have to do a deeper dive. So the inflammatory markers are elevated. So you ask yourself why. So then you take a look at the hormones. Well, the testosterone's 200. Okay. Testosterone deficiency has been proven to be a pro-inflammatory state.
Right.
And lo and behold, what happens when you take a patient with elevated inflammatory markers and get their testosterone levels up?
They start to come
Magic.
down. Yeah.
CRP comes down.
Yeah.
It's amazing. It's amazing. I've cured diabetes with testosterone.
Yeah, same. Diabetes, and all kinds of inflammatory processes.
Yeah. And so you have it. Again, functional cardiology looks at the root cause analysis, and you have to go as deep as your knowledge and technology allows you to go to really get to the root of that sometimes.
Right.
But it doesn't stop at lipids and statins.
So what's your opinion on why conventional cardiology doesn't have a tool yet to address the inflammation? Because it's just not taught. There's no drug. What is your opinion on that?
This is where people might consider me a conspiracy theorist, but I think a lot of what practice is about is what Big Pharma dictates to us.
Of course.
So Big Pharma doesn't really have an interest in creating a drug that lowers CRP.
Listen, why would they lower the one thing that is keeping it a multi-trillion-dollar industry?
Exactly.
Because inflammation is at the root of every, to your point, you already said it, chronic disease that pharma has a treatment for. So I agree with that. I just was going to see if you would say it.
I did say it, and I truly believe it. And I think that there are even a lot of traditional cardiologists who don't dabble in the functional space that would still contend that pharma has an iron
they know,
iron
but
grip.
There's no other tool in the toolbox, unfortunately.
Right.
And I love that you just kind of address this is where functional cardiology kind of splits off, is you really are dedicated and focused to the root cause. So I want to just kind of button up the cardiology conversation. If we're just talking about cardiovascular disease, we've talked about hormones and testosterone for sure, and estradiol in women is powerfully anti-inflammatory and an immunomodulator too, right? Sure. Because this immunomodulation plays a part in the disease process as well. But I'm always wanting to give our listeners some tangible things that they could stop doing today that could, if they were a patient in your office, you would say, these are some things you could easily change in your everyday life and your lifestyle and things that you're doing that could tip the needle away from inflammation a little bit. There's no way we're going to get away from all toxins. If you're a living, breathing human, we're sitting here in a toxic bath.
Sure.
But there are things that we could choose to do to decrease that toxic burden. So what's your opinion on that? What are your thoughts? Like, what would you tell somebody they could do just to start right now and decrease that toxic?
Sure. No, you can't, you bring up an interesting point, or an important point, is that you can't just throw nutraceuticals and hormones at everybody.
Yeah, exactly. Hormones and supplements are going to fix everything.
In the absence of lifestyle modification, the other stuff may help, but if you want to optimize your chances, all the things that your doctors have been telling you for years now, traditional doctors do have do have a place. Yes. And when they say diet and exercise, those are important, but yes. there's a physiologic foundation to all of that. Diet means low saturated fats.
Yes.
Means good proteins, good unsaturated fats, fiber, and not eating inflammatory foods. One of the biggest problems we have, and I don't blame the general public for not understanding this, but if you eat inflammatory cows, you're going to get inflammation.
Right.
I don't tell my patients not to eat beef. Eat grass-fed, grass-finished beef.
Right.
It has to be non-inflammatory beef, or else you're not doing yourself a favor. If you eat lean filet mignon that's made from a grass-fed, grass-finished cow, you're not going to develop hyperlipidemia from that.
That's right.
So the foods that you choose are important, and then exercise. There have been so many fascinating studies on exercise with regard to decreasing inflammatory markers.
Yes.
You can take somebody with an elevated CRP, just put them on a week-long program of walking. 30 minutes.
Nothing major, people. And you have to go join the gym.
And that's an important aspect of your question. Exercise does not mean you take up marathon running tomorrow.
Right, or boot camp or whatever.
Every cardiology study that says we exercise the patients, it's walking for the most part.
Right.
Right. So I'm not telling my patients
30 minutes a day,
most days of the week, And if you can do 4 out of 7, you're doing yourself a great favor. Yeah. So it's those basic things, eating a non-inflammatory diet, exercising that help, and then some common everyday things. You know what's one of the most potent therapies, and it's been shown in multiple trials just recently that helps to promote healthy cholesterol levels is just taking a tablespoon of olive oil.
Yeah.
The oleic acid in olive oil is a potent anti-inflammatory.
This disease is so low in the Mediterranean diet.
Yeah, it's amazing. You said simple things you could do for yourself.
Absolutely.
Take a spoon, pour some olive oil in it.
Yeah.
Drink it down.
And it's powerfully anti-inflammatory as well, correct?
Yeah. No, that's one of its benefits. So
and when I talk about an anti-inflammatory diet, people always say, "What does that mean?" And I just tell people, you got to meet people where they're at. And so if the one thing I would have you do would be to stop eating as much as you can anything that is in a package. Yeah. Right? I mean, packaged processed foods are probably one of the worst offenders of inflammation. And of course, sugar-laden foods, and most of those are sugar-laden foods. The last kind of myth I want to dispel around this, because there's still so many people operating under this low-fat diet,
right.
Being, the way, somehow this has stuck from the 80s and it, thankfully there's a lot of information coming out about, using beef tallows and, tallows to cook and real fat and full fats to cook, because they're not what's causing your problems. But what are your thoughts on that?
Yeah, and I will be the first to tell you that my own societies propagated those myths in the 70s and 80s.
Yeah, it made sense.
It made sense, but it wasn't founded in science.
Yeah.
That was the problem.
Yeah.
So,
like so much of what we do.
Right. So there was an established link between cholesterol and plaque and coronary disease. So the societies at the time immediately jumped on, we have to be on a low-fat, low-cholesterol diet.
Yeah.
Well, then what happened? Well, big food took over and said, okay, we're going to make low-fat, low-cholesterol stuff for you to eat.
Yep.
We're just going to put a ton of sugar in it.
And so, you got to give some flavor.
Yeah, they propagated the problem and created more diabetes and more coronary disease. Yep. And so, those myths, and that's why my favorite topic is eggs.
Yeah.
Every 5 years, eggs are good or bad for you, right?
Yeah.
But the original was, they're high in cholesterol, so you can't have them. Well, you only absorb about 15% of the cholesterol that you ingest, so the amount of cholesterol you're getting from an egg is hardly any, and
it has a lot of other.
It has a lot lot of benefits to
nutrients and benefits.
So yeah,
and the oranger the yolk, the better.
Exactly.
And then just when I'm excited about my orange yolk eggs, I see this whole thing on social media that, oh, those orange yolk eggs, they're just feeding their chickens marigold flowers. I'm like, stop it.
I read that too.
They taste good. I like them.
Yeah.
So I want to continue the conversations. We're going to do another show because I really want to get into inflammation as a root cause of all these other diseases and kind of go a little bit deeper about what you talk about in your book. But this was a good starting conversation around inflammation, cardiovascular disease, the role that testosterone plays and hormones play. We didn't get too deep into it, but I think we talked about it enough, and we've talked about it a lot on other shows. And then a couple of different tangible things that people can, start to do just to mitigate inflammation. If everybody can just take home this concept, and I've said it so many times, if people that have been listening to me for a while, we've talked about inflammation on the show. This is a different angle, which I love. But is there anything else in this conversation right now with what we've talked about that's missing, that you want to say, that you want to make sure people take away?
There's a couple things. We did hit on testosterone, and you mentioned estradiol kind of in passing.
Let's talk about it. It's my favorite hormone now.
Yeah, well, I understand why. But interestingly, in the 70s, research was done, and for good or bad, there was a lot of research done at the VA hospitals, right?
Mm-hmm.
But one of the most amazing pieces of data that came out of that was that in the 70s, they proved that estradiol therapy, actually in men, was one of the most potent ways to lower cholesterol.
Yes.
And so, you have to take that to heart, because a lot of women, I think, are afraid of estradiol because of the myths surrounding the women's health study, as you're an expert on. But estradiol, both in men and women, has an important function in cholesterol metabolism, in particular, enhancing the mass of LDL receptors for LDL clearance. And so I don't want to neglect estradiol's importance in cardiovascular health, because it's the jury is still out at whether it's primarily testosterone through its anti-inflammatory effects that helps men with cholesterol risk, or is it the conversion of testosterone to estradiol? And I'm going to tell you it's probably both.
It's probably both.
Because
I agree.
You see both pieces of evidence.
Well, you see that, you see it in the studies. You see them both impacting it.
Yeah.
Absolutely.
So I wanted to make sure we didn't.
I love that you brought that up, because no matter what, and there's some people that might be listening to this for the first time, and we've talked about it with different guests, but there is a fear around estrogen that's still there, even though the original authors of the Women's Health Initiative trial, number one, you brought it up. So let's just talk about it. In the WHI, if you really look at those trial results, all of the negative outcomes came from the progestin arm.
Exactly.
That is it. There is the only negative outcome out of the synthetic estrogen arm was a slight but statistically significant increased risk of clots because of the oral first pass metabolism modality. So all of this Alzheimer's disease, cardiovascular disease, breast cancer, all of those negative outcomes were from the progestin arm. In fact, the same authors just have in 2020 released a paper in JAMA stating that estrogen is actually the only drug that is shown in any double-blind, placebo-controlled trial to decrease all-cause mortality. Sure. All cause of death, any cause of death. And that's not bad, but that's my least favorite form of estrogen. So I do get very passionate about talking about estrogen, because so many people are still afraid of it. So many clinicians are still afraid of it. And all of that. And I don't fault any of them, because they're just operating under old information. Sure. You and I are kind of geeks for the literature, so we stay steeped in it. But the average clinician doesn't really have time, or wouldn't even know where to look for that kind of stuff, and are still just operating under those old guidelines. So we have to give estrogen some props, and estrogen plays a huge role in brain health and Alzheimer's disease. So thank you for bringing up my good friend estrogen. We're very good friends since I transitioned through menopause a few years ago. Sure. So I love my estrogen. But thank you so much for being with me. And I want to talk again, because we've still got a lot more to talk about.
My pleasure. This was fun. Awesome. Thank you.